My name is Dr. Ryan Kolhbrenner. I'm an assistant professor of clinical radiology at the University of California, San Francisco. And I'll be talking today about prostate artery embolization, focusing on topics that urologists really need to know. I have no financial interest to disclose. Here's a basic outline for today's lecture. We'll start with a very brief overview, since everyone watching is more of an expert than I am on the topic of BPH. We'll talk about potential PAE candidates. We'll discuss the workup, the procedure, and the post-procedure care. Finally, we'll talk about the current evidence supporting the use of PAE. Recall that benign prostatic hyperplasia is a very prevalent condition, with about half of men over 60 with at least one symptom related to prostate enlargement, although the subset requiring treatment is obviously smaller than this. Being such a prevalent condition, the costs are in the billions. As you know, the big categories of medical therapies are the alpha blockers and the 5-alpha reductase inhibitors, both of which improve symptoms of BPH by different mechanisms. These therapies have shown to be beneficial over placebo, although the improvement is modest, usually only a handful of points in the AUA symptom index scoring. There's a growing alphabet soup of surgical therapies for men with BPH, and this is a list of many of them. We'll be adding to the alphabet soup with PAE as it becomes more common in this country. PAE has actually been occasionally performed for years at UCSF, mainly for refractory bleeding in the setting of inoperable prostate cancer and only sometimes BPH. About 10 years ago, someone realized that a patient treated for bleeding had significant improvement in their urinary retentive symptoms as well. And since that time, the procedure's gained momentum in Portugal and Brazil especially, and numerous studies have shown its therapeutic benefits. The FDA tends to keep us behind the times here in the States, but the device for prostatic artery embolization finally gained FDA approval on June 22, 2017. Although we have been using the device, embospheres, for other indications for roughly 15 years. Prior to that, these embosphere particles, the small spherical sub-millimeter embosphere particles, were used only off-label for PAE. Who can get PAE? We base our assessment on the same symptom index as urologists do. The IPSS, or AUA symptom index, is a great way to stratify severity and follow clinical response over time. All of our patients fall in the range of severe based on the AUA score or the quality of life question. Obviously, if you have a patient with a chronic indwelling foley, you're assumed to have severe enough symptoms to warrant treatment, and you don't necessarily need to have answered these questions. We're looking for patients with sufficiently severe symptoms who have documented prostate enlargement. Usually finding BPH patients with 40-gram prostates is not difficult, but as the gland gets smaller, the arteries tend to get smaller as well, and the procedure can become that much more complicated. So 40 grams is my personal cutoff. Essentially, though, the bigger the gland, the easier it is to perform the procedure. And obviously, we don't want to be doing procedures on patients that are doing great on medical therapy alone, so I list the third criterion here as well. Renal failure is a relative contraindication, although these days we're realizing that contrast is far less of a harm to kidneys than originally thought. I personally still think twice about doing angiographic procedures on someone with a creatinine of greater than 2. Severe athero is something that I'll say no to just because it can make the procedure very difficult, if not impossible. Confounding disease of the lower urinary tract is a relative contraindication, but certainly everyone is considered on a case-by-case basis. If symptoms are predominantly thought to be due to BPH, even in the setting of, say, a mild urethral stricture, for example, that's perfectly fine. We know that TURP is often considered the gold standard, and that may not change anytime soon. So who can we actually help with PAE? And I think there are two large categories of patients. The patients who are not surgical candidates and the patients who don't want a transurethral procedure. The former includes people with 200, 300 gram prostates or people too sick to undergo general anesthesia. The latter includes typically younger people who have heard horror stories about TURP from a friend or relative and just want something else altogether. Let's talk about before, during, and after PAE. Every patient gets a creatinine, a platelet count, and an INR. Almost everyone has a PSA on file from the last year or two. I look for obstructive pattern on non-invasives and make sure there's no confounding disease noted on some cystoscopy if there is a report available. I look at prior ultrasounds and any biopsies if available. And if all this looks like a pretty solid case for BPH, I'll order a CT angiogram as a final step just to make sure the procedure is technically feasible. How do we do PAE? It's like any other embolization procedure in IR, where we place a small sheath into the artery and perform angiography to map out those arteries. We access the prostatic arteries on both sides with small microcatheters and inject these embosphere particles to stop the blood flow in the prostate. At the conclusion of the procedure, we remove the sheath, we close the artery, and patients are on bed rest for about 4 hours afterwards. Now at UCSF, we observe patients overnight and then send them home the next day. The twist on this procedure is that the anatomy is extremely variable. And classically, the prostatic artery will be the terminal branch of the inferior vesical artery from the internal pudendal artery. The reality is that the origin may be from any pelvic artery, and there can be crosstalk with other pelvic arteries as well, which makes careful embolization necessary. Here's an example of a right pelvic angiogram used for mapping purposes. The hypogastric or internal iliac artery bifurcates into an anterior and posterior division, if you recall. Regardless of origin, the gluteal arteries go posterior, and the internal pudendal and the obturator arteries go anterior. In this particular case, there's a bit of a variant. There's a common vesical artery here, giving branches to the top and bottom of the bladder, that gives rise to the prostatic artery right here. What we've done is navigated a microcatheter, a 2 French device, into the prostatic artery and performed an injection. The artery you can see here bifurcates into a capsular and central branch and appears to supply only the prostate. You can see a Foley catheter balloon placed prior to the procedure sitting atop the prostate throughout the procedure. This particular patient had a prior urolift that unfortunately didn't yield durable symptom response. And you can see the implants here and here. This is a coronal cone beam CT image generated during injection of the right prostatic artery, and we perform these to avoid non-target embolization of structures like the bladder or the rectum. In this image, you can see the contrast-filled Foley balloon sitting atop the prostate at the bladder base with opacification of multiple right-sided intraprostatic blood vessels. We did not see any filling of adjacent structures on this cone beam CT and opted to embolize at this particular location. Here's another patient undergoing PAE. We were working on the left in this patient at the time of this angiogram. You can see the major branches going posterior, the gluteal branches here and here. There is the internal pudendal artery here going anterior, as well as the obturator artery. In this particular case, the prostatic artery in green arises from the obturator artery, which happens to be my favorite origin because they're usually pretty easy to access. This is an unsubtracted angiogram from the proximal left prostatic artery, which, if we play out here, shows a somewhat large prostate gland. This gentleman had a 250-gram prostate. The vast majority of the contrast here flows anteriorly into the gland, but note that there is a small branch going posteriorly. We performed a cone beam CT at this location, those images I don't have, and found that this was a small sacrococcygeal branch. So what we did was further advance the microcatheter into the prostatic artery, and we've performed yet another injection. You can see that the central branch sweeps across the gland, communicates with branches on the other side of the prostate. You can also see the capsular branch coursing inframedially. In theory, you're treating both branches with PAE, but you could argue that the central branch is the more relevant of the two for BPH. After the procedure, we admit all of our patients to observation. Most places do this as an outpatient procedure, but we've always admitted all of our embolization patients at UCSF. We know that there are low-level communications with rectal, bladder, and seminal vesicle arterial branches that may be below the threshold for angiographic detection. So bleeding from some of these structures does occur once in a while, maybe 5 to 10% of cases. Macroscopic injury to any of these structures, though, is rare, but has been reported. UTI can occur immediately after the procedure, so I prescribe ciprofloxacin 500 milligrams twice daily for 7 days. Significant pain is not common after PAE, but we prescribe NSAIDs just in case. I will do a phone follow-up in 1 week just to make sure there are no issues arising. Notable symptom relief, though, usually doesn't occur until 2 to 4 weeks after the procedure. And I'll reassess the IPSS at that 1 month follow-up. We'll do 6 and 12-month follow-ups as well, and then patients are welcome to come back for follow-up if needed. Current evidence. So this is the meat of the talk. There are tons of papers on PAE now, and these are just some of the best known. We'll focus on the meta-analysis on top here. We'll focus on one of the prospective studies, and we'll also discuss a few smaller studies on patients with very large prostates and those with chronic indwelling Foleys. This is a meta-analysis that was published in JBIR in 2016, senior authored by the person who has likely done more PAEs than anyone in the world, Dr. Pisco of Portugal. They included 6 of the best studies available to date, encompassing roughly 500 patients. They look primarily at the subjective clinical outcomes and secondarily at the more objective outcomes, plus the IIEF, or the International Index of Erectile Function score. This graph shows the trend in the AUA score over time after PAE, with a drop of 13 points at the end of the first month, and a further decrease to 20 points overall by the end of the first year. The studies that have looked at these numbers long-term, even though there aren't enough to be included in the meta-analysis, show that this relief of symptoms can be sustained for years out. And the majority of patients, 75%, have sustained symptom relief for years after the procedure. Again, though, not enough to include it in this meta-analysis. Significant improvement of quality of life was noted after PAE, with roughly a 2.5 point improvement by the end of the first year. And this was in 425 patients. Shifting to the more objective criteria and first looking at post-void residual in 302 patients, we see that improvement of 60 cc's was present after the first month, eventually improving to 85 cc's by the end of the first year. Qmax improvement was modest, with a 5 to 6 cc per second improvement in peak flow 1 year after PAE, and this was in 312 patients. The PSA is sometimes used as a surrogate for prostate volume, and as PAE tends to shrink the gland, the PSA tends to decrease. By the end of the first year, the mean PSA will have decreased by about 2 points in patients undergoing PAE. Patients tend to care a lot about erectile function, and the IIEF score after 1 year was unchanged from baseline. There is one study here that suggested significant improvement from baseline, and one that suggested significant decline from baseline at 3 months, but there isn't much of a change when everyone is combined. It takes a while for the prostate to shrink to its new baseline size, with 306 patients having a decrease in prostatic volume by about 15 cc's at the 1 month mark. The new baseline is usually achieved by around 3 months, where a volume reduction of 30 cc's is very common. Adverse events are usually mild and include dysuria or self-limited rectal bleeding, hematuria, or hematospermia, as we discussed. Acute urinary retention can occur which may be related to bladder stunning, very uncommonly requires Foley catheter placement. And if it does, improvement after a week or two with the Foley catheter out is the norm. In terms of severe complications, bladder ischemia requiring repair occurred once, and severe UTI with sepsis requiring an ICU stay occurred once. This is out of a total of 662 patients, so overall a pretty good safety profile. Shifting gears to comparative studies, this paper was published in 2016 out of Brazil and compared TURP to PAE using the institution's original technique for PAE and the perfected technique that many places have adopted. Perfected refers to proximal embolization first, then embolize distal. And the idea is that you can squeeze more embolic into the arteries later on by wedging your small catheter way in there distally to the intraprostatic branches. There were 15 patients in each group, and they assessed IPSS, the IIEF, and the Qmax at 12 months on the patients they included. Interestingly, they made a point of assessing the degree of bladder outlet obstruction by urodynamic testing and also included measures of the bladder contractile index. All patients had a symptom score in the mid-20s and a quality of life score of between 4 and 5. Of note, the TURP patients had a higher Qmax at baseline and a higher bladder contractile index at baseline. The way it worked out, it's kind of strange. All TURP patients had strong contractility and only 1 of 30 PAE patients had strong contractility. All groups had significant improvement in IPSS with the greatest declines in the perfected PAE group and the TURP group. Both had mean post-procedure scores that were more than 20 points less than baseline. There were also large declines in quality of life scoring for all groups. Finally, the Qmax improved in all groups, but most significantly in the TURP group. And I think that the available research shows that PAE does not improve Qmax quite as much as TURP. But the difference here in the bladder contractile index suggests to me that these numbers may be a little bit farther apart than reality. This was a prospective study from 2015 where the authors focused solely on men with very enlarged prostates, specifically those that were greater than 90 grams in size. 35 of their 98 PAE patients seen during the study period met the study criteria for size, and all but 1 of those 35 were successfully embolized. These are the baseline characteristics for the 35 patients studied. Their prostates were 135 grams on average, and the IPSS score was 18.3 on average. The quality of life scores were nearly 5, with peak flow rates in the obstructed range. 7.1 was the mean. Their results 3 months out showed substantial drops in IPSS and quality of life scores. So there was roughly a 32% or 45 cubic centimeter decline in prostate volume. Although symptom scores are arguably the most important numbers to follow, it's always nice to see some objective evidence of improved Qmax, for example. And in this case, the Qmax increased by 114%. Prostate MRI is being increasingly performed at our institution for prostate cancers, but some institutions use it to follow PAE patients. In this more dramatic case from the same paper, there was a 150-gram decline after PAE. I tend to follow patients clinically rather than get follow-up imaging on everyone that may or may not be useful. This was another paper that studied a subgroup of BPH patients, except in this case it's not large prostate patients, it's patients with urinary retention necessitating Foley catheter placement. This was a small study. Only a small fraction of BPH patients have chronic catheters, and these 11 patients had their catheters in for a mean of 10.9 months. They studied the change in prostate volume over time for these patients and found roughly a 30% decrease in prostate volume that was sustained throughout the follow-up period. Of note here, 10 out of the 11 patients had their catheters successfully removed between post-procedure day 4 and 25. On average, patients were getting these out before 2 weeks. What we often see as some, or hopefully most, of the prostatic tissue infarcts is that the serum PSA spikes, as it did in this study. The day after the procedure, the mean PSA was found to be 85 before it returned to its new lower baseline at the 1 month mark. And this was sustained throughout the follow-up period. Quality of life significantly improved, as you would expect, with 10 of 11 patients having their catheters removed, with the average hovering in the pleased to delighted range from 30 days out and beyond. IPSS obviously could not be assessed at baseline because of the presence of these bladder catheters, but the scores for the entire follow-up period remained in the mild range, between 2 and 7. Just to complement the subjective symptom data, they did have some more objective measures of urinary function in these patients, with Qmax increasing to 10.8, not great, but probably out of the range of danger. The detrusor pressure on urodynamic testing decreased by 35, and the post-void residual dropped by 100 cc's at the end of the first year. In conclusion, PAE is a well-tolerated, minimally invasive procedure with very promising results. Although we don't expect PAE to take over, we do think there is a niche for this procedure and would encourage you to let us know if you have BPH patients that can't get general anesthesia, that have massively enlarged prostates, or who are fearful of transurethral procedures for any reason. And as I mentioned at the beginning of the talk, we historically have performed this procedure for hematuria, and it still works great for that indication. Thanks so much for your attention. Feel free to contact me by email, ryan.kolhbrenner@ucsf.edu.